Welcome to Optic Surgeon, the ophthalmology podcast. Today we're doing a deep dive into a really critical area, lens findings. This is all about equipping you with the essential knowledge. Whether you're seeing these cases in clinic or, prepping for exams, we'll explore everything from common cataracts to some of those rarer congenital quirks. Our mission really is to give you a clear, actionable understanding.
Absolutely. The lens is such a fascinating structure, and its abnormalities can signal a whole range of things, ocular conditions or even systemic diseases. Understanding these findings is just crucial for preserving vision and, well, ensuring comprehensive patient care. So yeah, let's unpack this.
Okay, let's start with a case, something to set the stage. Imagine you have say, 30-year-old patient. They've got a known history of Marfan syndrome, and they come in complaining of new blurred vision and maybe some double vision, but just in their right eye.
Right. So you get into the slit lamp, and what you notice pretty quickly is a supratemporally subluxated lens, meaning it's partially displaced kind of upwards and towards the temple.
hmm
And you might also see phacodenesis, that little bit of a tremble of the lens when the eye moves,
hmm
and maybe even some early cortical opacity starting.
Okay, so that combination right there, supratemporal subluxation, phycodenesis, it strongly suggests ectopia lentis, probably with an early cataract starting too. And this patient, they clearly need an urgent evaluation. It really highlights why understanding these lens findings is so important.
Exactly. It's often the first clue. So what exactly are lens findings? Well, fundamentally, they're any abnormality within the crystalline lens itself, the eye's natural focusing structure. And these can range from really common issues, things you see all the time, to much rarer conditions. Each one has its own implications.
Right. So we're talking about a whole spectrum, like obviously cataracts, opacities in the lens, but also things like a dislocated lens or ectopia lentis, where it's partially or completely out of place.
hmm And then you have things like iridescent lens particles, those little crystalline deposits,
Hmm.
or changes in the lens shape, like lenticonus, which is conical, or lentiglobus, more spherical.
And what about lens size?
Good point. Microspherophakia or microphakia, that's a abnormally small and often more spherical lens. Then there are those fetal remnants like persistent pupillary membrane or PPM, epicapsular stars, Mittendorf dots, basically leftover bits from development.
Fascinating. And less commonly, maybe, intralenticular foreign bodies, stuff actually in the lens.
Usually from trauma, yeah.
Yeah,
Or the complete opposite, aphakia, where there's no lens at all.
either congenitally or after surgery.
Right. And related to surgery, sometimes you can get retained lens fragments left behind.
Okay, quite a list. So how do these actually present? What symptoms should make us think lens?
Well, clinically, it really varies. Cataracts, as you'd expect, usually cause blurred vision, maybe glare, halos, especially noticeable at night. But ectopia lentis, the displaced lens, that often causes decreased vision in this very specific thing, monocular diplopia.
Double vision in just one eye.
Exactly. If a patient says they see double with one eye covered, you really need to think about lens position or maybe corneal issues, rather than, say, a muscle problem causing binocular double vision. It's a key differentiator.
That's a really useful clinical pearl. What about some of the others? Are they always causing problems?
Not always. Things like iridescent particles, lenticonus, microspherophakia, they might be asymptomatic initially, just picked up on routine exam,
Mm-hmm.
but they can cause blurred vision, and importantly, they can sometimes lead to secondary glaucoma, so you need to watch them.
Mm-hmm.
Fetal remnants like PPM are usually asymptomatic unless they're really dense or right in the visual axis. Same for a Falcacchia, though obviously that causes huge refractive error. But foreign bodies or retained fragments, they're much more likely to cause acute symptoms. Pain, redness, blurred vision, especially if they trigger inflammation.
Okay, so those are the symptoms. What about the signs? What are we actually seeing at the slit lamp?
Well, for cataracts, you'll see those distinct opacities, nuclear, cortical, posterior subcapsular. They look dark or white against the red reflex. With ectopia lentis, the main sign is that decentered lens. But also look for iridodenesis, a trembling iris, and phacodenesis, the lens trembling. The anterior chamber might look shallow too.
In the others.
You might literally see iridescent crystals or that distinct conical shape of lenticonus, or notice a very small lens diameter in microspherophakia, or, actually see retained fragments after surgery.
Right. And the significance, as we said, it's huge. From a benign Mittendorf dot to something vision-threatening like advanced cataracts or ectopia lentis causing glaucoma. And crucially, sometimes it's the first sign of a systemic disease like Marfan or Alport syndrome. The lens exam is just so revealing.
It really is. Now, thinking about the mechanisms, why do these things happen? Generally, it's down to developmental issues, degenerative processes like aging, inflammation, or trauma. So cataracts, for example, result from a disruption in the transparency of those lens fibers.
Mm.
Aging is the big one, but trauma or metabolic changes can do it too.
And ectopia lentis, that displaced lens. You mentioned the zonules.
Exactly. It's caused by weakening or even rupture of the zonules, those tiny ligaments holding the lens. When they break or stretch, the lens shifts.
Makes sense. What about those shimmery particles, iridescent particles?
They're basically crystalline deposits, often linked to metabolic things like calcium levels or sometimes even drug-related changes.
Interesting. And lenticanus, that cone shape, is that developmental?
Mostly, yeah. It's an abnormal growth of the lens capsule or cortex, often congenital. Microspherophakia is also a developmental lens size anomaly. Those fetal remnants, they happen when the fetal blood vessels supplying the lens don't regress completely before birth.
And foreign bodies or fragments are pretty straightforward, usually trauma or surgical complications.
Right, and aphakia is either congenital absence or, much more commonly, surgical removal.
Okay, so we have the what and the how, but let's dig into the why. What are the specific causes, both ocular and systemic?
Okay, focusing on ocular causes first. For cataracts beyond age, think trauma, chronic uveitis, maybe secondary to glaucoma, conditions like aniridia, or even a large persistent pupillary membrane.
And the types can with clues too, right? Like nuclear, cortical.
Definitely. Nuclear cortical spokes, posterior subcapsular, or congenital types like blue dot or sutural cataracts, they all have slightly different associations sometimes.
For ectopia lentis, trauma's a big one, obviously. But what else, just within the eye?
Pseudoexfoliation syndrome is a major non-traumatic cause that flaky material weakens the zonules. Also aniridia, congenital glaucoma, chronic uveitis, even rarely ciliary body tumors pushing the lens.
What about those iridescent lens particles again? Can they just happen?
They can be idiopathic, yes,
Mm.
but always worth thinking about hypocalcemia, hypothyroidism, or certain drugs like phenothiazines. Lenticonus lentiglobus, mostly congenital, sometimes linked to microphthalmia or persistent fetal vasculature. You might see that classic oil droplet red reflex.
Right, the oil droplet. And microspherophakia, microphakia,
Also congenital, think Peters anomaly or congenital rubella.
and things like PPM, epicapsular star, Mittendorf dot.
Usually just common congenital findings, often seen in infants. They look like little strands, star flecks, or a white dot, typically nasal for the Mittendorf dot.
Intralenticular foreign bodies, almost always trauma, right? Especially metal.
Yeah, iron or copper are particularly bad because they can cause toxic reactions like siderosis or chalcosis.
And aphakia, surgical or congenital, causes big refractive errors deep anterior chamber.
Exactly. And retained lens fragments, that's a complication of cataract surgery, often leads to inflammation and high IOP.
Okay, now for the really critical connections the systemic causes, where the lens finding is basically shouting about something else going on.
This is absolutely key. For cataracts, especially in younger patients, think diabetes, myotonic dystrophy,
Yeah.
Down syndrome, congenital rubella, Lowe syndrome, Wilson disease. The list is quite long.
And the big one for ectopia lentis.
Marfan syndrome, classic association often with that supratemporal subluxation up and out.
But not the only one.
Definitely not. Also, critically, homocystinuria. Here, the displacement is typically inferotemporal, down and in. That directionality is a huge clue.
Down and in for homocystinuria, up and out for Marfan. Got it.
Right. Other associations include Weil-Marchesani syndrome, Ehlers-Danlos, hyperlysinemia, sulfite oxidase deficiency, even congenital syphilis.
Wow, okay. What about lenticonus? Any systemic flags there?
Yes, think Alport syndrome for anterior lenticonus and Lowe syndrome for posterior lenticonus, both significant genetic conditions,
And microspherophakia.
can be seen in Weil-Marchesani, Marfan, Alport, and Lowe syndrome as well. It pops up in several of these connective tissue or metabolic disorders.
So a small spherical lens should definitely trigger a systemic thought process.
Absolutely. While things like PPM or foreign bodies don't have direct systemic links, the trauma causing them might unmask an underlying condition. Always keep the whole patient in mind.
Okay, fantastic overview. So let's get practical. You suspect a lens finding. What's the systematic workup? How do you approach the patient?
Start with a really thorough history. When did symptoms start? Congenital, acquired, any trauma, previous surgery. Ask about systemic symptoms, joint issues from Marfan, hearing loss for Alport, developmental delay, risk factors like diabetes, steroid use, family history.
And specifically about the vision blur, double vision glare, pain.
Exactly. Get all those details. Then The examination.
Where do we start?
The slit lamp, always. That's your main tool. Assess clarity, position, look for specific opacities, check the zonules if you can, look for foreign bodies. Then check the red reflex. It's quick and can instantly show opacities as dark shadows, or that oil droplet for lenticonus.
Onioscopy too.
Vital. Check the angle, especially with ectopia lentis or microspherophakia, risk of angle closure. Also look for angle recession after trauma.
And pressure.
Always measure the IOP, looking for glaucoma lens-induced pseudoexfoliation-related whatever it might be.
Yeah.
And don't forget a dilated fundus exam. Rule out retinal detachment or tumors, especially if the lens is displaced.
Okay, beyond the basic clinical exam, what other tests might be helpful?
Well, ultrasound biomicroscopy, UBM, is fantastic for visualizing lens position, zonules, even small foreign bodies, especially if the view is hazy. B-scan ultrasonography if you can't see the back because of a dense cataract.
What about OCT?
Anterior segment OCT, ASOCT, gives beautiful detailed images of the lens architecture and anterior chamber depth. Great for assessing glaucoma risk. And sometimes potential acuity testing is useful to estimate how much vision might improve after cataract surgery.
And if you do suspect a systemic link,
Then you need systemic tests, maybe a urine test like the sodium nitroprusside test for homocystinuria, enzyme tests for galactosemia, or genetic testing for Marfan, FBN1, Alport, COL4A genes, Lowe's syndrome. And definitely consider a referral to a geneticist, maybe a pediatrician or internist, for a full systemic workup. Don't hesitate on that.
right, makes sense. So we've done the workup. Now management. How do we decide what to do?
It's completely tailored. For cataracts, if they're mild, non-visually significant, like maybe some blue dot opacities, you just observe. If there's mild blur, try optical correction first glasses contacts. But if vision is significantly impacted, or there are complications like lens-induced glaucoma, then cataract extraction with an IOL is the way to go.
And for our Marfan patient with ectopia lentis.
Again, optical correction might help refractive error, but surgery is needed if it's causing amblyopia risk in a child, uncontrolled glaucoma, or significant uveitis. And that surgery might need special techniques like using capsular tension rings or sewing in an IOL because the natural support isn't there.
Okay. What about those iridescent particles?
Observe if asymptomatic, but definitely do a systemic workup to find and treat any underlying cause like myotonic dystrophy or hypothyroidism.
Lenticonus and microspherophakia.
Monitor closely for glaucoma and amblyopia. Lens extraction surgery becomes an option if vision is poor or glaucoma is developing.
And the fetal remnants, PPM, epicapsular star, Mittendorf dot.
Usually just observe. They rarely need any intervention.
Intralenticular foreign bodies.
Depends what it is. Inert stuff like glass,
Yeah.
you might observe. But reactive materials, iron, copper, that cause inflammation. They need surgical removal, often quite urgently.
Okay. Esophagia.
Needs optical correction, IOL, contacts, or apophakic glasses, and lifelong monitoring for retinal detachment risk.
And finally, retain lens fragments after surgery.
Initial management is often medical intense topical steroids for inflammation, IOP lowering drops. But if there are large nuclear chunks or the inflammation just isn't settling, then surgical vitrectomy to remove the fragments is often necessary.
Perfect. Okay, let's wrap this up. What are the absolute high-yield pearls, the things you absolutely need to remember from this deep dive?
Okay, here's a big one. You see a subluxated lens, maybe with iridodenesis, in a tall patient. Think Marfan syndrome immediately. Specifically look for that supratemporal displacement and make sure they get evaluated systemically.
And another red flag.
Dense cataracts plus high intraocular pressure. That screams lens-induced glaucoma. Don't just treat the pressure. This often needs urgent surgical intervention removing the lens.
So the action plan in those scenarios.
Immediate thorough slit lamp exam, gonioscopy, and consider UBM. Get the full picture of the lens and angle. And crucially, refer for genetic or systemic evaluation whenever you suspect an underlying condition. These lens findings are often just the tip of the iceberg. Timely management saves vision and sometimes limbs.
That's a wrap for today's deep dive.
Yeah, I really hope it brought some clarity to your clinical thinking on lens findings.
Until next time, stay focused, keep learning, and don't forget to subscribe for future insights.